Hey, welcome to EMS Challenge. This is a kind of a special edition. We had planned to be off today because police and fire games were going on. They are completed. Thanks for everybody that helped cover those. Great turnout of that stuff. But this is due to protocols came out like midnight, July 1st was the last copy that I saw online, and agencies were required to have an update before the 1st of August. So this will be a quick rendition, my thoughts on the protocols. I'm going to cover everything except some of the critical care. I will cover critical care pharmacology at Springville in 2 weeks. We'll cover that then. But these are my thoughts for this. EMS Challenge history, for those of you not aware, we started this back in 2014, I think, to bring more physician-led education in the field. If you heard me say this, you've heard me say it a million times. I think that the work that EMS does, pre-hospital medicine in the field, is medical care, and we as physicians, healthcare, mainstream healthcare should be involved in that because the work you do is important. People live or die based upon the care you provide, so we should be involved in that. So my thoughts on the protocols is my translation or paraphrase. I'm a non-denominational preacher, and I'm going to take the Bible, which is the protocols, and I'm going to pull things out of it to meet the needs that I think see fit. All right, just like religion. That was funny, wasn't it? Thank you very much. Inappropriate, nobody strike me down. My point to that is the protocols, there are a lot of things in there. You should get your knowledge base from other places, from your primary education, from current research, from literature, from your medical director, from organizations such as the NAEMT, or ACEP, or the National Association of EMS Physicians. Okay, this is a guideline for you guys to look at. There are some discrepancies in here, and I'm going to give you my input in what I think should be done with these. If I'm your medical director, please follow my advice, my guidance. If you have an issue with that, reach out to me. Okay. If I'm not your medical director, no harm, no foul. Talk to them, have a discussion about things you have questions about to make sure everyone's on the same page, because there's some pretty important things that you can do in this state as an EMT, an advanced EMT, or paramedic. Okay, so updates, thoughts, and just a friendly discussion about this. All right, disclosure, so I don't get in trouble from UAB, because through EMS Challenge we give both EMS Con Ed, we can give nursing continuing education credits, and we can provide physicians Con Ed as well. So for the docs on board, please look at your protocols that the state put out. Make sure you're happy with these, and discuss with the state as need be, or reach out to me. I can help you as well. Future dates for us will be in Springville in 2 weeks. I'll introduce our 2 new fellows there, Dr. Kirby and Dr. Sullivan. You'll be seeing them around the Birmingham area and the greater Birmingham area. Back in Irondale in August. And we got some pretty good venues coming up pretty soon. So 11th edition, again, this was printed off the document that was placed on the webpage on July 1st. For questions related to content, there are 2 people you can reach out to, or actually 3, Dr. Crawford, Dr. During for the pediatrics, and I may have cut Mr. Gray a break. I didn't put his contact information on there, or Mr. Gray, our director of EMS. So those are the ones you need to reach out to for content questions or issues. Feel free to reach out to your regional medical directors or your SMEC board members to address those as well. But again, these are the folks that sign off on these protocols. These are the ones that are in charge of their content. Sweet. So the way I'm going to kind of approach this is I'm going to talk about scope of practice. And then we'll go through the medications at each level. And then in the second hour, I'm going to just take the protocols themselves and run through them and point out some highlights that I think that are important. There's no way to go detailed into every protocol in 2 hours, but we will cover everything over the course of the year in EMS Challenge in more detail than the protocol talks about. Okay. So EMT, people refer to this as the basic EMT. I would say there's nothing basic about the EMT. I was talking to the class before we got started. The EMT is the backbone of the pre-hospital healthcare system, of pre-hospital medicine. Just like nursing is the backbone inside the health system itself. Without the EMT, people die. So super important. So things at the EMT, scope of practice, patient assessment, including taking and recording of vital signs and appropriate history. I would argue that's probably one of the most important things, even though it's kind of blown through sometimes in the general education or initial education for this, right? So history taking, the purpose of a history for anyone, whether you're an EMT, a medic, or an ER doctor, is to risk stratify your patient. Figure out what things matter, what things don't matter, which patient is at risk for having a bad outcome in front of you, right? So if I'm asking somebody the past medical history and they start telling me, yeah, I take vitamin D, vitamin C, I take some melatonin at night, do I actually care as an ER doctor? The answer to that is yes. I care deeply inside. But from a clinical standpoint, no, does not matter, doesn't change what I do. The things that I'm looking for are things that make that patient higher risk for having a bad outcome in the next 30 minutes to a couple of hours with me. For example, acute coronary syndrome, right? So we call that chest pain, right? A lot of times, but it's more than just chest pain. But if I have an older person having chest pain, I'm gonna start thinking about questions that make me think they're at more risk for having a heart attack, right? Questions could be what? Have you ever had a heart attack before? Yeah, cheat. Get to the answer. If they say yes, guess what? They're at high risk for having heart disease. They've already had a heart attack, right? So that doesn't change the care that I'm going to do because I'm still going to do everything I would for anybody without that history, but I'm going to move a little bit faster, maybe be a little bit more serious, maybe tell 3 less jokes to that patient before I take care of them. Does that make sense? It determines how fast I move to them. If that patient is 54, they smoke tobacco, they've been doing crack for the past couple of days, they had a heart attack 3 years ago, I'm going to be calling for ALS as an EMT a lot faster because they need a 12 lead and probably some advanced therapies. Does that make sense? Cool. Shortness of breath, dyspnea, stuff that matters, the STMs would be, hey, any history of asthma? They say yes. All right. Lots of folks have asthma in the Deep South, right? The next question I would say is, have you ever been admitted to the hospital for asthma? If they say yes, I know they have real underlying pathology. This isn't just exercise-induced asthma. I get it. That's important too. I'm not saying it's not. But people who have been admitted for asthma in the past have a higher risk of being readmitted. If you're admitted to the hospital for anything these days, that means you're pretty sick. We don't have a lot of beds. So that person is going to get me moving a little bit faster into my therapies, into my treatment. I'm going to be getting ALS transport coming to them as well. I'm moving a little bit faster. I'm risk stratifying them. They are at a higher risk than the person that has exercise-induced asthma or never wheezed before because of their history. Does that make sense? Yes, no, maybe, flip me off or something. Thank you for good. I saw that. Yes. Sweet. All right. Altered mental status. What things can we ask somebody that has a history that is now altered? What can we ask them or their family to determine are they high risk to having problems? Anybody know? Anybody care? Bueller? Sweet. So, hey, are you a diabetic? If they're in Alabama, I would argue you just assume they're diabetic, right? Fair enough. Did anybody go to the police and fire games? See the venues? At the end of every athletic event, they had this table, and they had water and juice and vegetables and fruit, all that stuff laying there, right? And all these guys from other countries would run through and take those things, right? What did the American table have at the end of the race? Anybody know? Yes, it was a hostess stand with little Debbie across from it. Exactly, right? We're all diabetics, right? So, any history of diabetes, that makes you go and get that glucose a little bit faster. Other things I think about, have you ever had a stroke? People who have strokes, okay, have a higher risk of having a long-term bleed because of that. Any kind of head injury, things of that nature that make you think maybe this is something besides somebody just drunk or acting a fool. Okay. When you talk about patient assessment, I like using the assessment triangle. This was initially started for pediatrics, and it was based upon general appearance of the kid, their skin circulation, and worker breathing. It's something you can do across the room, right? You can look at somebody and say, are they acting appropriately mentally, right? The 3-year-old that's not kicking and screaming and fighting as you get near them, that's inappropriate, right? But we can kind of translate this over into the adult world as well, general appearance. As you approach the patient, do they make eye contact? Are they looking at you? Are they talking to the folks around them? What do they look like? If their appearance is off, you know you got to pick up the pace and get hands-on for your assessment. Circulation in the skin, laying hands on them, checking for cap refill, getting a radial pulse versus a central pulse. Are they sweaty? Are they cold? What do they feel like? And then worker breathing. And I would argue that worker breathing is more important than rate of breathing. Rate of breathing, your respiratory rate, you'll be tested on in paramedic school and EMT school and medical school. It's a great test question. In reality, a rate of 12 per minute versus 18 per minute, not a big difference. What the big difference is their work of breathing. Are they using accessory muscles? Are they head bobbing? Can they talk in long sentences? So, for example, my breathing right now is pretty good because I've talked nonstop for 9.5 minutes. So you know I'm breathing pretty good. If I can only say 2 or 3 words and I got to stop and gasp for air, that's a red flag they're having a respiratory problem. Okay? Use that common sense a little bit. So work of breathing, a lot more important. All right? For mental status, I like using APU, alert, response to verbal, pain, or unresponsive. Okay, you can use the GCS, that is fine, but for me personally, that's on down the road. I'm going to say if they're unresponsive, responsive only to pain, one of those two, they're critically ill. I'm going to be doing life-saving maneuvers, opening the airway, manage that patient. If they're alert, working to verbal, I got time to do other exams, secondary exam on that person. There's a difference between heart rate and pulse rate, all right? The pulse rate is what you feel when you touch the patient. The heart rate is what that advanced EMT or medic or doctor sees on the cardiac monitor. It's more important to do that pulse rate that gives you, is it bounding? Is it strong? Are they sweaty? Is it not there? Things of that nature. Central versus peripheral pulses, really important in kids. If you have a kid that's a little bit dry, delayed cap refill, no distal pulse, but has a good central pulse, you know their volume down. You don't need a blood pressure right now. You need to start your interventions on that person. Okay. And then temperature, another state requires we have a thermometer on ambulances. Who here has ever taken a temperature on a patient in the field before? Raise your hand. Oh, wow. Okay, I guess I'm just behind the game. Yeah, I don't do that often. I say, yep, you're hot, or yep, you're cold. So very good. Sweet. So patient assessment, super important for these folks. This is the next redneck slide that I worked on. This is, if you look at the yellow is all airway stuff, airway and breathing. So super important, okay? And that's why the EMT does these things, because if these things are not addressed in the field in the first few minutes, people die. And that is the goal of the EMT, is to help prevent morbidity and mortality, right? So use of oxygen, okay? OPAs, NPAs, blind airway insertion devices, the BVM, mouth-to-mask device. I don't do that anymore. I'm not saying you can't, but I'm saying if you work at a place that doesn't have a BVM, you probably need to talk to somebody or move along, right? Pulse oximetry is super important. And then use of suction equipment as well. So that's all airway. Cardiopulmonary CPR. So that's the use of airway devices, AED, recognizing if they're dead, moving ACLS there. If we're lucky, a lot of these early cardiac arrest situations can be resolved with basic airway techniques and the AED. Anybody here ever delivered a kid? Any of the EMTs? Yep, great. So you can do as much as I can do as a doctor, right? The OB folks do a lot more. We'll cover that in Springville. We're going to talk about OB emergencies there. But you can be held to the same standard as I am, all right? Because technically, your scope of practice says you can deliver these non-simple burrs. That's on the next page. Spinal motion restriction, we'll hit that on the main slide when we talk about the protocols, but remember that historically, long backboards were used to mobilize the spine. They actually do not do that. A long backboard's a great extrication device to get someone out of the car, get them down the steps, but it does nothing really for the spine. The only time we're keeping somebody on a long backboard these days is if they have blunt trauma and obvious paralysis. Now, you can use a long backboard to help immobilize the pelvis or bilateral femur fractures, or to keep the really obese patient from moving around. That's reasonable. But remember, long backboards really don't do much for spinal immobilization. And anybody that has a penetrating injury and is paralyzed, long backboards, seat collars do no good whatsoever. No need for that. But you can see the scope of practice for the EMT is pretty great. A lot of things they can do. More yellow things, CPAP. So the EMT can use CPAP. We'll talk about CPAP use in a few minutes. And then for the agencies that have ventilators, the EMT is allowed to even use BiPAP, which is a great way to rescue someone from fluid volume overload, pulmonary edema. Medications that the EMT can use, my hope had been that we would be able to move to the EMT using agency carried epinephrine for anaphylaxis. That did not come through this time. However, if your patient does have an auto injector, whether it be for any medication, epi or something else, you can help them use that. But Tylenol, albuterol, aspirin, Narcan, and glucose are the drugs that are approved on the EMT formulary. So primary exam, for years we talked to ABCs, which is great. American Heart changed it up to CAB. We added a D for disability. A lot of ways to do that. I would say that the approach to trauma on any patient, if you think about your ABCs, is airway and maintenance while holding C-spine immobilization. However, if the patient does need repositioning, that's reasonable because people that aren't breathing have to breathe or they die. Breathing and ventilation, hemorrhage control, disability, that's the assessment of the neurological status. I would use the APU, right, to include getting the glucose in everyone, and then the exposure and environmental control. In reality, what you're really talking about is the approach to trauma. As you recognize a patient has been injured, you can be, as you approach that patient, you look at them, looking at for things that are crooked, looking for things that are squirting blood. You stop massive bleeding first. This is a nonlinear approach. If you show up on an industrial accident and they're missing part of their arm, you're not going to go open their airway as that arm is pumping out blood. It's hands-on, direct pressure. If that fixes it, great. If not, you move into a tourniquet or pressure points to stop that bleeding. Right? And then at that point, you're going to move protecting the airway. Do they repositioning, suctioning? Are they breathing? Do they have out of breath sounds? The chest moving? Okay. Do they need supplemental oxygenation? And I would argue that if you're having to do any kind of airway repositioning, they get oxygen. There's no risk to oxygen in the pre-hospital world. Okay. Unless your patient is on fire. Cool. What is the pulse rate? Right? If the pulse rate is too fast or too slow, I would say forget getting the blood pressure for a few minutes. Look for other life threats such as active hemorrhage. Right? Work on establishing things that help them. Maybe it's raising the legs, maybe it's hemorrhage control, maybe it's having the advanced EMT start IV access. Neurological status we talked about. I'm going to use APU. That gives me enough information. All right. And then the E for this is, am I missing something else? What else is going on? Sick patients, patients that make you uncomfortable, that are altered or unresponsive, that are dying in front of you, you cut their clothes off, you get them naked. You look for other life threats. You don't want to be the person that mixes the fact they got a gunshot wound to the groin because they also had one to the chest, and they're bleeding from the groin and the chest, and you just saw the chest wound. Non-trauma, ABCs, we already talked about. In reality, what we're going to talk about here is that if the non-trauma patient, as you approach them, if they have no pulse, we start chest compressions. That buys you time to figure out what causes this arrest, and you can fix it if you can. So you approach the patient, you recognize they're altered using that assessment triangle. You see no work of breathing, you kneel down, you're checking a carotid pulse. As you're opening the airway, no pulse, you're telling your partner, hey, start chest compressions. And when do you stop chest compressions once you start them? I can think of 3 reasons to stop chest compressions. And 1, they wake up and they tell you to stop. Hey, dude, that kind of hurts. Stop. Right? That's great. Right? The other would be you stop to look for a shockable rhythm with your AED as an advanced EMT, as an EMT. And the third thing would be is after ALS gets there or you recognize the patient is dead and we're not going to do any other resuscitation, that's when you stop chest compressions. In my opinion, there's no 30 to 2. We're not checking for long periods. It's continuous chest compressions as you intervene. Suction and adjuncts. A lot of times these folks, when you start chest compressions, will have some vomitus. So you can have somebody to clear the airway. Maybe it's just turning the head to the side and taking their shirt up and getting the vomit out. You cannot oxygenate through pools of vomit or blood. So you got to clear that. All right. We've already talked about work of breathing. The way I count for respirations, if they did have a pulse, would be I would count for 6 seconds and multiply times 10. So I'm looking at them. What's their work of breathing? They're working pretty hard. They breathe 3 times in 6 seconds. So 3 times 10 is 30. That gives me a number so I can fill out my paperwork. Okay. Oxygenation, again, oxygen is good for people that are sick and dying in front of you. And the P's, the P stands for position and pressure. If the patient is awake, they have a pulse, they're working hard to breathe, nobody breathes well laying flat on their back. So you're doing supplemental oxygen, you're going to sit them up so they can breathe better. And if you make the decision that they need positive pressure, you can start CPAP or BVM with those people. Those are your pressure. What medicines can we give as the EMT to help someone breathe? So you got someone who's a little bit confused. They're breathing 30 times a minute, working really hard. They can only talk in 2-word sentences. And when you listen to the lung sounds, they're wheezing. What drug are you going to give them as an EMT? Albuterol. Very good. Sweet. Limited risk, almost all benefit. Okay. What if their heart rate was 130? Respirations are 30. Blood pressure is fine. They're working hard to breathe. And you actually have a SAT probe with you, and the SAT probe says it's 89%. Can they still get albuterol? Yes or no? Go like this. Yes. What if the heart rate's 140? Yes. Why is their heart rate so fast? Because they're not breathing well. Albuterol will increase your heart rate, but that's okay. They're hypoxic and working hard. Albuterol, limited risk, almost all benefit. Cool. We talked about heart rate versus pulse rate. Okay. Blood pressure, IV access for the advanced EMT, except in some states, the EMT can take a course and learn how to do that. Supportive meds and therapies, that would be like the albuterol we talked about. AFPU, we mentioned, and then check a glucose. The EMT can check a glucose, gives a lot of information. If it reads low, you know what the problem is. If it reads high, they're on the other end of the spectrum. Anything in between, it just means it went to Auburn for undergrad, right? Very good. Some Alabama people here. I got a little bit of response. Sweet. But that information is useful as that advanced EMT or medic gets there. Hey, Mr. Smith, breathing 30 times a minute, a little bit hypoxic, better with albuterol. Glucose was 460. As the advanced EMT, I'm going to start thinking about the interventions and therapies that I can do to help this patient. Then E, am I missing something else? Is the patient getting better? They should be getting better if I'm doing the right things. If they're not getting better, one or two things is going on. Either I've missed it and I'm doing the wrong stuff, or it just ain't working. Either way, you reassess, right? So you don't miss things. So my approach to this is the ABCs. I like using a different mnemonic, semi-inappropriate, but it's assess and manage oxygenation, ventilation, vascular support, control, vascular status, whatever you want to call it, and neurosalvage. And I say salvage because if someone has an underlying brain injury, we can't fix that primary injury. That part of the brain is gone from a GSW, from a stroke, from whatever. We can prevent secondary brain injury, and that is our goal as EMS providers and as ER doctors. This is nonlinear, so if you're working with a 2-man crew, as you approach the patient, you're going to recognize, oh, dude's not breathing. Hey, you open his airway, I'm going to check a pulse. Oh, he's got no pulse. I'm going to start chest compressions. Then your buddy will start the O2 and then go get the AED. We don't ventilate. It's a nonlinear approach. Everybody knows their role in the ABCs, right? Or this other mnemonic, all right? The 4 things that matter, and you work as a team. If you got a 3-man crew, even better. You got more hands. Sometimes you get the citizens to help you as well. So same thing for me in the ER, maybe working in a small hospital where it's me, 2 nurses, and a custodian. Cardiac arrest comes in. Guess what? Everybody's getting to work right now. And the reason I talk about oxygen, ventilation, vascular control, and neurosalvage is because you're going to do this as an EMT. You're going to do this as an advanced EMT. We do this as doctors. We do this as in the ICU, except we just add more medications, more things we can do, and more assessment skills. But it's all about supporting oxygen, ventilation, vascular control, and neurosalvage. So whether you're an EMT, whether you're a nurse, whether you're a grumpy old ER doctor, everything is the same. Oxygen, ventilation, vascular support, and neurosalvage. Those are our ABCs. Sweet. So airway, when you open that airway, we're looking for things that occlude the airway, looking for patches. I found fentanyl patches shoved in people's mouths before. I found nicotine patches, things that people suck on to get high. It's crazy. You're looking for blood, for vomit, right? I like vomit, one of my favorite body fluids. It's great. Skull, anybody here dip? Don't answer that question. Can't tell you how many times I found skull bandits or tobacco in the mouth. Looking for objects that cause people to choke. And you want to clear those things out because without a clear airway, you really can't provide passive oxygenation for people. The way I recommend we give passive O2 in the pre-hospital world is a nasal cannula. Yes, the textbook says this is low flow. I got it. In reality, this is a great way to give somebody oxygen. You can start at 2 liters, titrate to effect. If the patient is altered and unresponsive or working hard and you got a nasal cannula on them and they become unresponsive and you got to ventilate them, you don't have to switch this off. If it was a non-rebreather comes off, ambu bag goes on. With this, you just take out your ambu bag, put it over that, and ventilate with them. You could actually buy ambu bags that don't have O2 tubing. attached to them, the smaller ones, and use over this. If this doesn't fix the patient's hypoxia and they're breathing on their own, the next step you go to is a non-rebreather on top of that, my opinion. Now, as a medic, if the patient is, or even an EMT, if you have a ventilator, if the patient is upright and you think they're in volume overload and needs CPAP or positive pressure, you can put your CPAP or BiPAP over that nasal cannula instead. If the patient is unresponsive, nasal trumpets are a great way to play. You slide that in. No gag reflex, you can put your nasal cannula on top of that. Great way to get passive oxygenation, and you fix one of the 4 pillars we got to take care of, right, which is oxygenation. Ambu bag goes on top of that, and you can ventilate over that. OPAs, always carried an OPA in my pocket. When I would take someone and I'd put them on the ventilator and intubate them, I always had an OPA in my pocket, so if I couldn't ventilate them well without it, I'd slide that in and manage the airway. In reality now, what I'm going to do instead is I'm going to use a blind airway insertion device. Same things that you as an EMT can use. This is the iGel. There's about 3 brands that I've seen used in our state. There's the iGel, there's the King, and the AirQ. You can pick, all right? I like the iGel, but pick what you want. The iGel's got an O2 port. You can break that little tab off there and put oxygen on it so that O2 is always running for the patient. If you're doing chest compressions, they get microventilations, they get oxygenation. You don't have to ventilate sometimes. I'm not saying don't ventilate, but I'm saying that you get microventilations. And I'll show some waveform capnography from cardiac arrest, actual cardiac arrest, here in the next couple of weeks to show you how that works. So medication formulary, new format for all protocols. The boxes on the side tell you which level a provider can do the procedure. So the EMT can use albuterol or albuterol ipratropium, right? No risk to that. I thought I had a question. I guess I'm hearing voices. Narcan is another drug approved for EMTs to use. Narcan intranasally. My advice, if the patient has no pulse, they don't get Narcan. What do they get? Chest compressions. Narcan's not going to work on someone that has no pulse when you give it nasally. There's no blood flow to the nose, okay? If you have 5 people on scene and you got somebody doing chest compressions and you have someone else that is doing passive O2, opening the airway, using suction, ventilating, right? You have the AED on, all right? You've already determined there's not a shockable rhythm. You've cut their clothes off. You look for other life threats and you're waiting for ALS and you're just bored and want to try Narcan then, more power to you. But it should not take away from the life-saving interventions of managing oxygenation and ventilation. If you're giving someone Narcan, they should already have an open airway, passive O2, and you should be ventilating them. Opioids make you not breathe. Sometimes they drop your blood pressure. And when you don't breathe, you die. You as an EMT should be able to manage that airway. That is in your scope of practice. Open the airway, clear it, passive O2, ventilate them, right? So Narcan. All right, the advanced EMT, 1 more semester of training gives you a lot of information, a lot of things that you can do. I would argue the most important thing, you get more experience and you're able to recognize sick versus not sick faster. And by sick, I mean that's someone that you think may die in the next 30 minutes to a couple of hours in front of you, right? But they can start IVs, they can do IOs. The state says they can now do 3-lead interpretation to recognize is it too fast, too slow, or shockable. They cannot defibrillate or cardiovert. They still got to use AED mode. This is agency specific, so you as an advanced EMT can discuss this with your agency medical director. They can check you off, credential you, and you'll be able to use the EKG monitor to recognize certain dysrhythmias. Okay? Wait. The advanced EMT should be the expert on all these things. This is the EMT scope of practice. Okay? So the EMT should be a master of the airway, hemorrhage control, cardiac arrest management, basic OB delivery, recognizing sick or not sick, getting the APU, getting the glucose, using oxygen, airway insertion devices, etc. The EMT should be 1 step up, right? But when EMT gets on scene, the advanced EMT should have these things done so that the advanced EMT can do the advanced things such as IV access and other medication administration. It's all EMT still. So the EMT is the foundation of everything that we do. All right, the advanced EMT formulary. So Tylenol, albuterol is the same. Aspirin, we didn't talk much about aspirin. So for the EMT, if someone is having acute coronary syndrome symptoms, and I would argue chest pain is one, right? If you want to give them aspirin, that is reasonable. If they're actually having a heart attack, aspirin is beneficial. Contraindications will be allergy, or they are on blood thinners, or have a history of GI bleeding. Those contraindications are same for the advanced EMT. They change as a medic when you can interpret a 12 lead, though. Albuterol's there. All right, so the advanced EMT can use antibiotics now, Ancef or Rocephin. Those are both cephalosporins. The protocols talk about you can use those for open fractures or suspected sepsis. My thoughts, my recommendation, open fractures, great. Ancef is a great drug. The sooner you get antibiotics into an open fracture, the better off they are, the less risk of having getting an infection there. Sepsis depends on what bug, what thing is septic, what part of their body, right? So talk to your medical control physician, determine are you going to use Rocephin or not. Rocephin is good for some things, but not good for other things. But Ancef and Rocephin are available for the advanced EMT. Decadron is available. Decadron can be used in asthma and allergic reactions. You can use it as a backup for patients who have adrenal insufficiency as well. The big drug for the advanced EMT is epinephrine in cardiac arrest and anaphylaxis. So currently the EMT can only use epinephrine via an EpiPen if the patient has it. So the advanced EMT will be the one that has the epi for anaphylaxis. So the advanced EMT should know the dose of epi and how to give it. In cardiac arrest, it's 1 to 10,000 is 1 cc. There's a pediatric dose. Y'all should know that as well as the advanced EMT. It's 0.1 mils per kilo, right? But epi, that's the big deal for the advanced EMT. They can hang lactated ringers. They can also use solumedrol. Solumedrol is a cheaper. We use that mostly for like COPD and asthma exacerbations. You can also use it for anaphylaxis after the epi. Contraindications to steroids would be pregnancy, all right, or history of diabetes because it can make your glucose go up. The exception to that would be if you have a patient in front of you who is dying from COPD or anaphylaxis, you hit them with a couple of doses of epi, and they're pregnant and a diabetic, and you're concerned about giving them prednisone, but you look at that patient and you think they're sick, guess what? They still get the prednisone, solumedrol. Versed can be given intranasal by the advanced EMT for seizures. And even though the advanced EMT can give IV medications, they cannot give IV Versed. That is outside their scope of practice. The risk of giving someone Versed is the fact they may stop breathing for you. So we're going to use intranasal. There's pretty good data that IN or IM Versed works about as good as IV, and it's faster because you don't have to start an IV. But for the advanced EMT, it is intranasal dose only. They can use Narcan just like anyone else can. But remember, if you're giving someone Narcan, it's because they're not breathing. You should be ventilating them. We're not giving Narcan for the ultra-mental patient. We're giving the Narcan for the person who is ultra because they're not breathing. Nitroglycerin. So the advanced EMT can give nitro. You give it in chest pain patients that you think is ACS. I think the state talks about you got to have a blood pressure greater than 100. My advice would be you also have to have an IV access that's free flowing because nitro will drop that blood pressure, and the heart gets its blood pressure, gets its perfusion from that blood pressure as well. So if you have someone who's having a heart attack and you pop some nitro in them and you drop the blood pressure below 80 or even below 100, it's going to make them worse instead of better. So IV access, then nitro. You can also use nitro for congestive heart failure. I think I'll talk about that here in a second. Yeah. So congestive heart failure is pretty prominent in the Deep South. It's caused by hypertension and diabetes and underlying heart disease. We see a lot of this. Don't get congestive heart failure confused with pulmonary edema. There's a difference. Pulmonary edema comes from congestive heart failure, but pulmonary edema is what kills you, and that is fluid in the lungs, right? So blood pressure gets real high, heart can't pump the blood out of the lungs get full of fluid. Patient lays back flat, they get confused, they get hypoxic, they got to sit up to breathe. So that's why we talked about the P's or that position. You sit them up, it gives them the chance to aerate the upper portions of the lungs so they don't get hypoxic. All right, position and pressure. If you have CPAP or BiPAP, You can put that mask on there, and that pressure forces that air, the fluid out and down. They breathe better. It also, what that pressure does, is it decreases blood return to the heart because it increases the pressure in the chest. So there's less blood going into the lungs. So usually you can clear that fluid in a matter of 30 minutes, 40 minutes if you're using CPAP on these folks. That's better than putting them on the ventilator, better than doing other things. So position and pressure. Obviously, they get oxygen right off the bat. That is an EMT skill, as is this. Blood pressure, if it's greater than 120 or 130, you can pop a nitrile under their tongue. It's going to lower the blood pressure, decrease the amount of fluid in the lungs. Great way to do it. The advanced EMT cannot give morphine. The medic can. The advanced EMT cannot give Lasix. But these three things right here, nitro, oxygen, and position and pressure, can usually resolve pulmonary edema, and the patient does not go into cardiac arrest from that. If they were to go into cardiac arrest, what's the first thing that we do for these folks? They lose a pulse with that because they're so hypoxic. We're going to lay them flat, start chest compressions, and ventilate them. When we lay them flat, what happens? The fluid, they drown. So you got to plan in advance so we don't kill our patients. The advanced EMT can do Zofran. Zofran is, what does Zofran do? Anybody know? Any Alabama fans here? Raise your hand from Alabama. You've taken Zofran several times. I know you have. All right, yeah. Zofran is a great antiemetic. Drink too many PBRs, you get nauseous. So you take Zofran. Zofran is a pretty good drug, right? Thiamine is another drug the state says you can carry. I've probably given thiamine 3 times IV in the past year. We don't use that a lot. It's an optional drug. If you want to get it, that's great. That's between you and your medical director. Places that I work, we really don't carry that much anymore. Racemic epinephrine is a great drug for for airway issues. It's in the protocols for the dosages. Limited risk, great benefit. You can actually make your own if you need to out of epi. The problem is that sometimes epi itself for cardiac arrest is hard to find. So I'd hate to waste it, to nebulize it, but sometimes you got to do what you got to do. Toradol is approved for the advanced EMT. Toradol is it's like IV Motrin. I'm not saying don't give Motrin via IV. That's a comparison, right? It's a non-steroidal anti-inflammatory. It's a non-opioid pain medicine. I think that's why I got put in the system. Toradol is great for young people with muscle strains. The problem with Toradol, that is, if you're pregnant and you give it, you can hurt the baby. If you have underlying kidney issues, you can hurt your kidneys permanently by giving someone Toradol IV. So my advice in the Deep South, I don't use Toradol a lot because I would argue that a lot of our patients have underlying kidney problems that you won't know as an advanced EMT, or I won't even know as an ER doctor until we get labs back, right? So the dose is also 15 milligrams, not 30. That dose has come down drastically over the past 10 years. We started out doing 60, then it was 30, then it was 15, just because we know that it actually does pretty significant damage to the kidneys. I would argue that besides epi, this is the most important drug the advanced EMT can give. This is used in in hemorrhagic shock. It's TXA. This drug makes your body say, hey, I don't want to break down a clot. I want to keep all my clots patent and strong so people don't bleed out. Great drug for hemorrhagic shock, traumatic resuscitation, limited risk, great benefit. We got a handful of intermediate EMTs out there. We're not recertifying any new ones. The state is not. But the intermediate can still intubate and use electrical therapy, unlike the advanced EMT. All right, this is the gold standard, the paramedic. This is what everybody wants to do. This is actually practicing medicine in the field, the things that you're allowed to do. You can pace people. You can place gastric tubes. You can give blood products now. The state says that you can do needle cricothyrotomy. Needle crics are really only good for oxygenation. You can't ventilate through that, in my opinion. It is an optional procedure. If you work at a place where I'm a medical director, we are not doing needle crics. The risk, in my opinion, outweighs the benefit for that. And we're happy to talk about that offline if you want to. And then chest decompression for the advanced EMT. And speaking of that, September 12th, and then that weekend, I'll be doing a cadaver lab in Birmingham. It should be online sometime in August. It's a free cadaver lab. You can do IOs, chest decompression. We can even do some surgical airways if you're interested. All right, this is the pharmacology, the formulary for the advanced EMT. So 3% saline used in head injuries is optional. If you carry it, great. I I'm not a big fan of it. I know that UAB trauma still uses it a lot. It's an osmotic, kind of shifts the fluid, decreases cerebral edema. I think there are better things that we can do in the field. We'll talk about head injury in a few minutes, but it is out there if you want to do it. Adenosine, I'm going to cover. Albuterol, we've already talked about. Amiodarone. There are two drugs out there that you can use for VTAC, VFib arrest. There's amio and lidocaine. There's actually a national shortage of amiodarone. I know a lot of places are going back to lidocaine. Amiodarone has a lot of long-term issues. Don't use it as much in the hospital. So either one, amio or lidocaine, you got to have one. Don't have to have the other. My thoughts on cardiac arrest: if you give someone amiodarone and you defibrillate them, they come back out into a sinus rhythm, you get ROSC. Places that I work, we're not starting amiodarone drips or lidocaine drips. Now, if you're practicing out in the rural community and you have an hour-and-a-half transport and your patient starts throwing runs of PVCs, runs of VTAC, that's reasonable. But routine post-arrest care, I'm not doing that. I think there's a limited need for that. Plus, there's limited availability of these medications. These are optional drugs, the calcium gluconate and calcium chloride. I would argue that places that I work, well, I would argue they're not optional. In places that I work, we're going to carry this. Calcium chloride is a great drug for hyperkalemia. It's a great drug for hypotension. It's like a dirty vasopressor. Limited risk, great benefit. There were some studies done in the early 2000s that talked about cardiac arrest outcomes did not improve with calcium chloride, and that's true. Some of them don't, unless you're hyperkalemic, right? Or you had a calcium channel blocker on board. So calcium, limited risk, great benefit. DILT, I want to talk about diltiazem. Diltiazem is approved for paramedics to use in the treatment of atrial fibrillation with RVR. Remember, AFib RVR is a response to something else. Most of the time, it's not the initial problem. It's due to dehydration, sepsis, some kind of insult. You treat that insult first. Treat the patient, not the monitor. Diltiazem slows the heart rate and lowers the blood pressure. If someone has AFib and they have underlying heart problems and their heart rate is fast because they got to have a fast heart rate to get perfusion, and you slow their heart rate down, you actually make them worse. So my thoughts, if you're carrying DILT, you better be ready with something else after you give DILT. So the dose for DILT is 10 milligrams, slow IV push, then a maintenance drip. All right. You can also repeat the bolus of 20 milligrams. That's a fairly low dose. The problem that I've seen, though, is people are buying the 100 milligram bag of DILT, giving 10 mgs out of that, then hanging it, put it on the dial-the-flow. And then sometimes you look down and holy crap, that IV that was in the AC and their arm is now straight, and that dial-flow was set at 30 cc's an hour or whatever drop you got it set at, and now you reposition that IV. Next thing you know, that whole bag is in, and that will kill patients. So if you're using diltiazem as an infusion in the pre-hospital world, my recommendation, you have a pump. Or you just do your first bolus, wait 5 or 10 minutes. If that doesn't work, do a second bolus. And if that doesn't work, don't do a drip. The goal here is you don't want to do things that kill people. All right. You can also use amiodarone for AFib, for AFib. Not a big fan of it, but it's an option. I'd also say there's no harm in calling med control on these patients. Get a little bit of help on the phone with those. Don't hurt your patients. Glucagon. Glucagon is pretty expensive. You can use it intramuscular to increase glucose on people that are not skinny. So they have to look like an Alabamian for glucagon to work. Skinny folks, does not help them. The other problem with glucagon is it's pretty expensive. Some folks are saying they want to carry it now because you can use it for beta blocker overdose, and that's great. But the dose for beta blocker overdose is 5 to 10 milligrams versus 1 milligram. And we're talking about thousands of dollars. And I can tell you right now, I've probably used high dose glucagon probably 4 or 5 times in my career for beta blockers. That's probably more of an ER procedure. Okay. And it's also fairly rare. Cyanokit is an optional drug, but I'd recommend using it, especially if you're fire-based. Cyanokit will reverse the effects of cyanide toxicity. There's a lot of cyanide in everything that burns these days. Okay, so a lot of good data out there on that. I can pull cases from the city of Birmingham as well. That the Cyanokit makes a huge difference, limited risk. It is about $900 a pop, so not every ambulance in your agency should have it, but it should be on every fire scene, on every supervisor's vehicle for the private EMS. Ketamine, dose of ketamine change, max dose is 300 milligrams. It is still ideal body weight. I would still argue that IV ketamine is restricted for critical care. IV ketamine has a big risk to making someone not breathe. A lot of issues with that. I think I got some cases in a few minutes to talk about it. Labetalol and nicardipine is in the paramedic formulary as well. These are drugs that lower the blood pressure. My thoughts, there's no reason to lower the blood pressure in the field because you have to figure out what's causing that hypertension. So if they're hypertensive, is dirt, diaphoretic, and their EKG is a STEMI, you've got nitro to fix it. If they're hypertensive as dirt and altered and you think in a stroke, you can't tell is it a hemorrhagic or ischemic in the field. If it's hemorrhagic, yep, you want the blood pressure lower. If it's ischemic, you don't. If you lower it, you're going to kill the brain. You're going to cause more secondary brain injury. So not a big fan of these antihypertensives in the field. In a facility, it's reasonable once you have imaging. The other thing is I would say that there's no way in heck I would hang Cardine without a pump. Because if you let the whole bag of Cardine go into somebody, right, over the course of 15 minutes, you literally just killed your patient. Risk to benefit. We talked about lidocaine. Magnesium is an optional drug, but I would argue it should not be. It's the drug of choice in torsades. It's also a reasonable drug to use sometimes in just VTAC. If your patient is eclamptic or pregnant and having seizures, it's a great drug for that. I think MAG is super cheap, low risk, high yield. Places that I'm working at, we're carrying MAG. Versed, they changed some of the doses of Versed we'll talk about in the second half. It's also going to be used for agitation now. Medics can also use Ativan, the Razapam. Problem with that is on national back order, and it also has to be refrigerated. Otherwise, it only has a 2-week shelf life. Valium is it's an older drug, but if it's all we got, it's all we got. Levofed was added as well. This is a great presser for patients that are septic or hypotensive post-arrest. Again, my thoughts are if you're using this, you got to have it on a drip, a pump. If not, I actually like dopamine or push-dose epi better, and I'm happy to talk offline about that. Pitocin. Look at there. It looks like it's required now. Is it? Oh, nope. I squinted. I got excited for a second. I didn't think it was. Pitocin we'll talk about next month or in 2 weeks. It's a reasonable drug to have out there. Great for postpartum hemorrhage, limited risk, and it's fairly cheap as well. Sodium bicarb. A lot of folks do like sodium bicarb in cardiac arrest. That's reasonable. You give sodium bicarb if you're acidotic in cardiac arrest. I would argue, though, that if you're acidotic in cardiac arrest, you're also hyperkalemic, so they need calcium first. So places that I work and I'm over, I suggest calcium before bicarb. If you're thinking bicarb, great, roll tide, give it after your calcium. We talked about thiamine, we talked about Toradol, we talked about TXA. All right, so you dispatch for a seizure. Patient is not breathing, has no pulse. When the 3-person crew arrives, what are they going to do? Non-linear, right? They recognize the patient doesn't have a pulse. Somebody start chest compressions. We're going to manage oxygenation, ventilation, vascular control, and save the brain. All right, non-linear, so no pulse, somebody's on the chest. Someone else is breaking out the nasal cannula, putting that on the patient, cranking it up to 15 liters. Because once we get oxygen on that patient and we're doing chest compressions, we got some microventilation. So oxygen and ventilation is being cared for right at that point. Someone else is going to get the AED, looking for a way to save the vascular support. If they're in VTAC or VFib with that AED, you can potentially get them out of that. All right. Someone else is cutting the clothes off, checking the glucose. When they come back with the AED, they're going to hook that up. Someone slides around, and we're going to start BVM at that point. All right. If the patient is huge and it's hard to ventilate them with a nasal trumpet and a BVM, they can slide a iGel in and switch the O2 over to that. But it's non-linear. Okay. They deliver a shock. No response. ALS arrives. We got an advanced EMT. The advanced EMT should not have to go over and help manage that airway or put the AED on or cut the clothes off or have a glucose done. The advanced EMT should say, oh, crap, they're doing chest compressions. As they approach, they should get a quick report from that EMT. Hey, dude was dead. We started chest compression. We shocked him twice. Glucose is 200. All right. The advanced EMT Should go ahead and start IV access and give what drug? The magic drug in cardiac arrest, epinephrine. Start fluids, all right? If they've had that training on the 3 leads, they put their monitor on, they're looking for a shockable rhythm, all right? They start IV fluids, all right? When the medic gets on scene, that advanced EMT should give a report. Hey, they started chest compressions, hit him with the AED 3 times. I got IV, gave him fluids. Glucose was 200. I gave him 1 epi. Medic's like, great, roll tide. Let me see your monitor. Oh, that looks like torsades, right? Now they give them magnesium and more epi and electricity. Maybe they take that airway and they put an ET tube in with capnography and start reading that instead. Maybe they bring the Lucas device, put the Lucas device on. They get ROSC on the patient because the EMT did their job and the advanced EMT did their job. Now the medic's going to do that more critical care type stuff, right? The physician level care. Oh, dude's now alive. I got a 12 lead. Is it a STEMI? Is it not a STEMI? I'm going to make sure the blood pressure is up. Okay, post-ROSC care. All right. Patient now gets to the ER, bring them to me. Great job. EMT did the work. Advanced EMT did their job. Medic did his job. Got them into the STEMI system. All I've got to do now is get a few labs, either lyse him for his STEMI, call a cardiologist, get him the cath lab. I can start chilling this person, or I can call a vascular surgeon and put him on ECMO to buy us even more time. This is nonlinear. We work as a team. Everybody knows the priorities and does their job based upon their scope of practice. Wait, same thing for traumas. All right, dispatching a GSW. As you approach the patient as the EMT, the patient is breathing slow, they're altered. You kneel down, they have a weak radial pulse. All right, you're going to expose that patient. You can look for life threats. They have holes in their chest, the belly, the groin. You're going to put direct pressure and start packing those holes. If they have an extremity injury, no matter how minimal, you're going to put a tourniquet on it. Because who knows, maybe they bled out of that extremity wound and not that chest or belly wound, right? You can start passive oxygenation, all right? You can be calling for ALS. You're probably not going to want to ventilate this guy unless he's not breathing completely. Because if you start to do positive pressure ventilation on this guy, what happens to his blood pressure? Normally, it drops, right? So passive O2, open the airway, packing wounds, packing holes, tourniquets, right? The advanced EMT gets on scene. They're going to start IV access because the EMTs can say, hey, dude got shot twice in the belly and his groin. I've got him packed. I got a tourniquet on that leg, and I've got O2. The advanced EMT is going to drop profanity in their brain, right? Start IV access, push the TXA, get fluids going, and waiting for the paramedic to get there. When the paramedic gets there, the hope is in the near future that as a region, we have access to blood products everywhere. At that point, quick reports given to the medic. They're hanging blood products. They should not be going to manage the airway or packing wounds, putting a tourniquet on, or doing O2. They should do the things that the medic should be doing. Maybe the guy is hypotensive, so they're hanging blood and giving push dose epi to get that blood pressure up to save the brain, because they know here in a little bit he's either going to wake up with the blood or he needs an airway, and when he gets an airway, it's going to drop his blood pressure. All right. At the ER, we're going to do more blood. We can start antibiotics. If they're shot in the chest, have a pneumothorax, they get a chest tube. Maybe they go to the OR. We manage them that way. Does that make sense? Yes, no? I think 3 people are awake. Very good. This is good. Questions, comments, or statements about this portion of the protocols? What I'm going to do, we can take about a 5-minute break, and then when we come back, I'm going to go through the protocols. There's no way to hit every slide. I'm going to try to hit some hot points. If there are questions online, you can put them in the chat box. Uh-oh, we got some. I can tell by the expression. Yes, sir.
Yeah, so we've got a couple been waiting for a little while. One is about using epinephrine drip in cardiac arrest. So seems to be some widespread confusion on what the new protocol says about that. So is it saying that they should give 3 milligrams, then the drip, or you do the drip right away, or you do the drip instead of the bolus, or what's the rate? How come there's not a rate listed, so on and so forth?
Yeah. I'm going to cover some of that in the second hour, but the short version of that is talk to your medical director and get a plan how you're going to manage that. What the state is saying is you have a max of 3 milligrams to give in cardiac arrest, or you can do a drip instead. My philosophy is in cardiac arrest, first dose epi is important. You get that as soon as you can. After first dose epi, then you got to figure out what caused that arrest. You got to figure out what made this happen and make that determination. Is more epi beneficial or not beneficial? Currently, my practice is first dose epi as quick as you can, second dose at 5 minutes, third dose 5 minutes later. We're probably going to start pushing that out even further. So first dose epi as quick as you can, second dose epi at 5 minutes, third at maybe 8 minutes or 10 minutes, and then you can make a decision, are you going to start a drip? I think the intent of the protocol was you can either do the push dose epi, or you can put a milligram of epi in a bag of 250 and start it and run that as an infusion during the cardiac arrest, just wide open. So there are different ways to skin the cat. I shouldn't say skin the cat.
I understand the confusion because the way it's written, the
Yes, sir.
concentration is very ambiguous. The flow rate's very ambiguous.
Right, right. So I would say what you got to do, you need to get with your offline medical director and determine what needs to be done. The other caveat that we have is at the bottom of the protocols, it says follow ACLS guidelines, AHA guidelines, right? So there's a lot of variability there as well. So get with your medical director.
All right. We had a comment that said epi auto injector was added to the EMT scope of practice in the 11th edition. I think actually EMTs have had the scope of practice to use an auto injector for quite a long time, but it's not on the formulary.
Right.
We're not buying epi auto injectors and carrying it with us to the scene. The EMT can use the epi auto injector if the patient has it. Is that correct?
That is correct. Yes. I wish that we could buy them and put them on the EMT trucks. I wish we had epi auto injectors and AED stations with tourniquets too, but yeah.
You're going to have every EMS officer ready to lynch you if you talk about epi ends. Yeah.
Yes. Yes.
All right.
My name is Paul. Well, never mind. I'm going to change my name.
So another comment here was talking about BiPAP and CPAP for the advanced EMT scope of practice, or I guess it's in the EMT scope of practice.
It is in the EMT scope of practice.
So the question is does that allow us to treat unresponsive, minimally responsive respiratory distress patients? So I would say that if they're unresponsive, then you need to ventilate them with a back valve mask.
Right.
That's a contraindication for BiPAP and CPAP.
That is a contraindication. But again, I would say talk to your medical director, because I can tell you that in the ER, my practice is if someone is altered unresponsive and they're hypoxic, sometimes I'm better off putting them on some passive O2 and putting that nice fancy mask on for BiPAP and getting good positive pressure, getting a lot of PEEP in there, oxygenate them before I take that mask off and intubate them. So there's a risk to giving someone CPAP or BiPAP or BVM if they're altered. The risk is they could vomit, you're going to flood their airways, have them aspirate. So again, that's a discussion for your offline medical director. But you're right, technically, altered mental status is a contraindication to CPAP or BiPAP.
Yep. So we also have somebody ask, well, how do we check off an advanced EMT for 3 lead use? I don't know the answer to that.
The answer to that is you must have your medical director for your agency must come up with an educational plan in writing, and they must educate you and then sign you off. It is an agency-specific plan. It does not have to be taught in the primary education. It's agency-specific, and it's geared by what that medical director wants.
Okay.
Yes, sir. Thank you for smiling. That was sarcasm.
So we also have Stephen from Office of EMS saying that the new drug list on the web will be updated to reflect the new protocols soon. So apparently there's still some discrepancy there that Office of EMS is aware of.
Oh, sweet. All right. Thank you. I'm glad they're on. Wonderful.
So we're going to take here about a 5 or 10 minute break. Thank you everybody for joining. Don't go anywhere. We'll be back with a lot more updates on the new protocols.
All right, folks, we'll get going. I know we're running a little bit late. Again, I cannot stress enough that each agency should get with their medical director and review these protocols. In the BRIMS region, we're requiring the medical director and the lead administrative person and their educator sign off that everyone has protocol updates. These are super important, all right? All right, so what I did is I just took the protocols off the website and turn them into a PowerPoint. We'll kind of go through some of these and hit some of the hot topics that I think are important in the time that we have left. There was a question posed to me at the break about tourniquet use. And I would argue that if you have a patient that you approach and they're in hemorrhagic shock, altered, make you uncomfortable, you think they're a sick patient, and they have an extremity wound, although we talk about, yes, you got to pack the wound, put direct pressure on that, that's all great. If that tourniquet is there, tourniquet goes on. We can always take that down later. Okay. The goal is to save lives. And sometimes you can look at a wound and realize, holy crap, that's probably not going to fix with my finger in that hole or an ABD pad. Put a tourniquet on that. If someone is altered in hemorrhagic shock and they have both a truncal injury and an extremity, put a tourniquet on that extremity wound. Don't not pack the other wounds. Don't not start your IV and hang your blood, start your TXA, but put a tourniquet on it. I've got several cases in the city of Birmingham where we've had patients who had extremity injuries in addition to belly wounds or pelvic wounds. We start blood volume resuscitation. They wake up and we look, and lo and behold, that extremity injury we thought was minor is now squirting blood out. Tourniquets are not going to hurt somebody in the short term. We went through scope for practice. Let's see if this is the one I got marked up. Paramedic. Acute health systems. Please review these. Remember, the statewide trauma system is super important. We're one of the only states in the U.S. that is able to track a patient from point of injury to rehab. Super important. But we got to utilize this. Remember, there's certain things that make you get into the system right off the bat. And in the Birmingham area, if you have physiological criteria, you're going to end up at UAB 99.9% of the time. Okay? There's some discretionary things. One of the things that you're going to think about with discretion for EMT discretion would be if someone is on a blood thinner. Important question to ask. The guy that falls off the bike and smacks his head and is now altered, wife says he takes Eliquis. That sounds like a reasonable EMT discretion trauma system entry, right? Wait. Stroke system, I won't talk much about that. We've hit that hot and heavy recently. Again, remember, utilize the stroke system. Remember that we are triaging to the LVO centers, which in the Birmingham area is Brookwood or UAB. So if your IMSA score is 4 or greater, you'll end up there, and that's their own divert. If your IMSA score is less than 4, you're going to end up somewhere else. That doesn't mean we don't think they're not having a stroke. That means that we're going to get them to that hospital, get them scanned, and make a decision, can they get a thrombolytic or not? And then because you put them in the system, we can move them from hospital A to hospital B pretty quick. Use the system. There's sometimes that one of these bigger hospitals are on complete diversion. We're trying to save those beds for the LVOs, right? So use the system. STEMI system, which is regional, not statewide yet, same thing. Remember, you as a medic should better read a 12 lead. As a medic, if you think that 12 lead is a STEMI, but it doesn't say star, acute MI or STEMI, call TCC. You want to put it in under EMT discretion. You would send that EKG to TCC. They will send it to the hospital that is open that you want to go to. The doc of that hospital will say, yep, it's a STEMI, or no, it's not. Either way, they go to that cath lab hospital, all right? That way, if you're right, the patient survives, right? If you're wrong, the patient still survives. Wait, all right. So general patient care, if you look here, the the EMT does everything in primary survey. We call it BLS care. I say that is BS. It's airway management, ventilation control, right? Oxidation, ventilation, vascular support, because you recognize, holy crap, something ain't good. You start chest compressions on the medical, or you call them for ALS, or you're defibrillating. And the trauma, same thing. You're going to be putting tourniquets on, packing wounds, calling for ALS, right? You're checking the glucose, you're doing your APU. The EMT is one of the most important links in survival for all of us. I cannot stress that enough. Please do not say it's basic EMT. There's nothing basic about it. Abdominal pain, I was looking through this. Remember, abdominal pain can also be ACS, acute coronary syndrome. Our protocols say ages 50 or greater. In reality, I've seen folks under 30 in their mid-20s having STEMIs as well. Always think about it. Remember, acute coronary syndrome is not just chest pain. It is shortness of breath. It is weakness. It is dyspnea. It is syncope. It's the 80-year-old lift assist you go to that don't feel good. A 12 lead, there is no risk doing a 12 lead. And guess what? An EMT can do a 12 lead if you have the monitor, right? The good news is, state says you can. The state also says as an EMT, you can do capnography. So that should be making more agencies invest in the monitors that can do AED, 12 lead, and capnography, so that we really can get more advanced medical care in all parts of our state, not just the parts that have money or in big cities. A lot of these pages I don't have marked. If you have a question online or in class about some of these, let me know. I think there's 180 slides. No way in dirt to get through all those today. Adrenal insufficiency, a lot of information. I would say if you have a question about any of these protocols or the medical complaint, look up adrenal insufficiency. Start at Wikipedia. Read that. Understand that. Then go to some of the journals and look it up and figure out what's going on. Most of these folks know if they have adrenal insufficiency. All right. What is that? That's hydrocortisone. So for the advanced up to critical care can give this. This statement is more for the critical care guy. So if you have someone who is septic, hypotensive, not getting better with IV fluids or vasopressors, or if I have someone that I'm starting on my second vasopressor, I've started norepinephrine on them, they've got fluids, I'm doing push dose epi, and they're still hypotensive, you think adrenal insufficiency. They get hydrocortisone. I know a lot of EMS agencies aren't going to carry this. It's expensive. That is fine. Is a interfacility transfer. If you're a medic or a flight nurse, and you're at hospital A and you're taking your patient to hospital B for a high level of care, and the story kind of goes out, hey, Mrs. Smith is septic, altered, hypotensive. We got them on epi and a norepi drip. They got antibiotics. They're still hypotensive and look like dirt. The first thing you should think of, oh, on two pressors, they could be adrenally suppressed. I need some hydrocortisone. Okay? It's a great way to get somebody's blood pressure up. Allergic reaction. Our protocols talk about you can use epinephrine 1 to 10,000 IV for refractory anaphylaxis. I would argue first dose of epi is 1 to 1,000 IM for anaphylaxis, whether you're an advanced EMT or a doctor. Second dose of epi for anaphylaxis is 3 minutes later, and it's 1 to 1,000 IM. Third dose of epi for anaphylaxis, whether you're an advanced EMT all the way up to a physician, is 1 to 1,000 epi IM. Okay? When you start thinking about doing IV epi for anaphylaxis, there's a huge risk that you're missing something else is going on. This is a rare thing. The other risk that you have is giving too much epi and causing a dysrhythmia. If it's a pediatric patient, that risk is less because they're younger. If you got a 50-year-old having anaphylaxis and you start giving epi IV and you give the wrong dose, big risk to cause cardiac ischemia. If you're giving someone epi IV and they're not dead, the 1 to 10,000, right? You should be calling med control and confirming that. Or my argument is you probably shouldn't be doing that anyway. You should be hanging an epi drip or calling med control and doing push dose epi of the 1 to 100,000. Yes, sir.
Hey, Doc, I'm sorry to interrupt you. We've got a fair amount of communication about epi and confusion regarding that.
Yep.
And so there's some folks that are seeing somewhere that epi max dose is at 3 milligrams. I don't find that anywhere in the new protocol, but I may be missing it.
I got a slide on that here in a second.
Okay. I'm sorry.
No, you're
we'll
fine.
Wait for you to get to it.
Yeah, we'll get to, there is a max dose of 3 milligrams. And that's just changed, but I think I got a slide on that. Yeah. The other thing is I would look at, double check, do not use the dosages out of the protocols. Always double check your dosages and make sure that's correct. There's some typos in here too when it comes to epi. I think I got those marked. So this is for paramedics, epi and anaphylaxis, refractory to other things. So if you have anaphylaxis, they should already got O2, IM, epi, maybe albuterol, maybe some steroids, another epi. If they're still refractory, we can talk about doing some 1 to 10,000. My advice would be go ahead and plan out with your offline medical director what you're going to do, whether it be start an epi infusion or switch to epi microdose 1 to 100,000. You can, but remember, if you're doing 1 to 10,000 epi on a person and they're alive, you better double check that and make sure you're right, because that can cause a lot of problems. I would be uncomfortable doing that in the ER as an ER physician. I would do a different concentration or start a drip. Okay? So that is category B, which we don't say a lot, which basically means call a doctor and ask. Okay? And it's not mother may I, it's hey, Something ain't right. What's going on? My most common experience with anaphylaxis is someone who has a severe allergy to some sort of food and they get it. For example, the person who has a nut allergy and they eat 3 or 4 chocolate chip and nut cookies, all of a sudden they have anaphylaxis, right? You give them an epi, they get a little bit better. 10 minutes later, it comes right back. It's because they just ate 3 dozen chocolate chip cookies with peanuts in it, right? And then they may need a drip because they're going to rebound over and over again. Altered mental status, huge gambit of diagnoses, right? Think about things that kill people first. What are some things that can make you altered and unresponsive that kill you? You're dead. Exactly. No pulse. Check a pulse. What else? Low glucose. I can fix that, right? Head injuries, opioid overdoses. Maybe they were shot in the belly and then put a shirt on to go to the hospital. Expose them, get them naked. Look for things that kill people, all right? Psychiatric patients can be altered. Most of the times, the ones that make me uncomfortable are the ones that are altered, naked, throwing things at you and fighting you, okay? That's a different altered mental status than the person that's unresponsive. So this is a huge gambit of things. When we talk about psych patients, some places talk about having tiered response, and is it ALS or BLS? If you think about it, if the patient is a little bit psyche, right, and they can calm with verbal reassurance, it's still under the EMT or BLS transport guidelines. That changes when they become combative and you can't calm them verbally. So that makes me think maybe it should be ALS. Discuss it with your offline medical director. Determine how you're going to manage these. If that psych patient that is acutely hallucinating, responding to internal stimulus, a little bit suicidal, is nice and calm with you, when you get in the back of the truck, does that mean they're going to be calm and nice all the way to the hospital? Probably not. Anybody here married? Raise your hand. Very good. I'll rest my case. That was funny. Or not. All right. So medications for acutely psychotic patients, we don't use the phrase excited delirium. We can use acute agitation with threats to the person or the crew. Ketamine is still ideal body weight. We talked about that millions of times on EMS challenge. All right, 2 to 4 mg per kilo IM. I've got places that I work, we have a cheat sheet based upon height, not weight. Okay, we're maxing out at 300 milligrams. You can also use Haldol if you want to. You can add some Benadryl in there with them. Works pretty decent. Takes a little bit longer. And now we can also use Versed for this. So I'm not sure why we're doing intranasal. If I can give somebody intranasal Versed, they're probably not agitated, to be honest with you. But 2 to 4 milligrams. I wish the dose was a little bit bigger. In reality, in my practice in the ER, I'm using about 0.1 mg per kilogram of Versed, maxing out at 8 or 10. Remember, if you mix Versed with Benadryl, they get sleepier, risk of airway compromise. If you mix ketamine with any of these other ones, same thing. Anytime you give these patients or something to sedate them or keep them from being aggressive for their safety and your safety and for the duty that you got to do, right? They become a critical patient. Once they are calm and chillaxed, you expose them. They get on the 3-lead monitor. They get capnography if you got it. If they get hypoxic, they get oxygen and opening airway because they get hypoxic after this because they're not breathing well. So you make sure they're breathing well. You get a 12-lead, you get a glucose. They are critical patients. Asthma, we talked a lot about asthma and COPD. This talks about the pathway. If you get down and they're still working hard after your albuterol and steroids, they can do MAG or epi, right? I would say that's an and. If I'm giving someone magnesium in the field because they're in COPD or asthmatic extremis, they're going to be getting epi as well. Epi is a great bronchial dilator. We used to use a drug called terbutaline, but epi works well. Now, if your patient is 90, and they say they have asthma, and they got a pack of Marlboros next to their chair, and they're working hard to breathe, I would bet you my $7 I got left till the end of July that it's probably not asthma. It's probably COPD, and I probably would not be giving them epi because they're freaking 90. But otherwise, epi is a great drug for refractory wheezing. IM epi, not IV epi. Bites and innovation. Just a reminder that UAB does have a snake bite clinic. We have toxicology that take care of snakes all the time. Take your patient where you want to. There's no statewide snake center, whatever. But UAB does have a snake bite clinic, and we can admit and take care of those folks. Do not bring the snake. Yes. Or if you do, it rides up front with the driver. That was that. That's funny. All right. What is this? Cardiac arrest. Maybe I can read it down here. No, ain't no way I can read it down there. Okay. This was actually the 10th edition as well, but I wanted to highlight it. And it talks about patients with penetrating chest trauma and cardiac arrest. Can somebody read that, what it says to do or not to do? Can somebody read that? Yeah, not chest compressions. Thank you for reading that with good eyesight. So there's a difference between medical and traumatic arrest. So our state protocols even allow that if a patient has a penetrating chest trauma, maybe they're dead from the chest trauma and it's not that the heart just stopped. Chest compressions don't really help you if you're low volume. So I arrive on scene, dude's talking to me. He stops talking. He's got a gunshot wound in his chest. I feel he has no pulse. What's the first thing I'm going to do after I use profanity? I'm going to thank the EMT for putting nasal cannula on him, crank that up to 15 liters, going to open the airway. As the medic, I'm going to reach over, I'm going to break out my needle and think, what kills you quickly in penetrating chest trauma? Tension in the thorax is a great thing that kills you, right? I'm going to decompress the affected side. If he fixes him and he wakes up, we say roll tide together, high five each other, he goes to the hospital. If he doesn't, I decompress the unaffected side because sometimes bullets cross the midline, right? Right? If that doesn't work, then you got to make the decision. Do I transport this guy or do I not transport this guy? If you're working at an agency that has blood products, that's the guy that you're putting your line in or you're drilling, you're pushing TXA, and you're slamming a unit of blood in this guy in a matter of 3 minutes in the hopes that you get enough volume back in the guy that he lives and you can get to the hospital. So this is actually a good thing for our state. I'm not saying don't do chest compressions on patients that are dead. That is not what Dr. Ferguson is saying. What I am saying is think about their cause of death and try to fix the things that you can. Penetrating chest trauma, tension pneumothorax, you can fix pretty quick as a medic. What about cardiac tamponade? Can y'all fix that? Not yet. Ultrasounds are coming to the field. At some point, maybe we can. All right. What about volume states, hemorrhagic shock? Can y'all fix that? 5 years ago, we said no. Some places you can now. So great stuff. All right. What is that squiggly line? Oh, I've already talked about if you give it my thoughts, if you're giving someone sodium bicarb, you should already give them calcium because if you give them sodium bicarb, you're thinking they're acidotic for the most point. And if they're acidotic, they're going to be hyperkalemic. Calcium is the drug of choice for that. Okay. There's some ingestions you can give sodium bicarb for. Those are the exceptions. Those are rare. I would say for the average medic, average doc, this is what you want to go by. Some of these flow charts are a little bit hard to follow. And I mean, it's not all of them are right. So, but my point to this is remember, these are guidelines. You should understand the principles of pediatric cardiac arrest, neonatal cardiac arrest, and adult cardiac arrest. You should know how to manage those patients based upon current AHA guidelines. Then you come back and you look and you say, oh, yeah, this actually does coincide, go along with that, right? And you and your partner know how to manage those patients. There's no way to break this sheet out if you got a 6-month-old in front of you that is dying. You got to know how to do your job before you get there. Okay? This should reinforce what you already understand and know. Okay? There's no way to follow this step by step in cardiac arrest. This is the new bradycardia. It's kind of going by what we talked about. Talks about the drugs that we use. And if y'all heard me talk about this, if it's too slow, I think about 3 things that make you bradycardic: drugs, electrolyte, hyperkalemia, right? Or ischemia. So it's talking about stable versus unstable. I would argue if they're stable, and by stable, that means good blood pressure, good perfusion, awake and alert, they don't need anything. 12 lead, supplemental care, roll tide, go to the hospital. If they're unstable, I'm doing atropine first. Thinking about dopamine. I'm thinking about push dose epi, and I can't read that screen either. The push dose to epi dose, double check that, guys. That is not correct. You can also think about calcium because slow and wide can always be hyperkalemia. We talked about bicarb already. If you think they're hyperkalemic, albuterol is another drug that you can use as an EMT, an advanced, or a paramedic. The dose is 20 mgs. So 20 milligrams of albuterol, if that means you got to give 5 doses of ipratropium bromide, that's all you got, no harm, no foul. It still works. Pacing is great if you're convinced 100% that it's third-degree heart block and not something else. So you got to be sure. My advice is, I got a patient that's altered, heart rate in the 40s or 30s. I'm going to be doing passive O2, exposing the patient, get them on the 3-lead, IV access, somebody's checking the glucose. Is the medic is drawing up atropine and pushing the atropine? If that fixes them, great. If it doesn't, I'm doing calcium. Then I'm starting push dose epi or dopamine. You could also use some norepi, which is going to increase the blood pressure, but not the heart rate, but only if you got a pump, my opinion, right? And then at that point, if that's not working, you're going to go to pacing. I would say that the majority of the folks that I've seen, even in complete heart block in the past 10 years, most of them I can fix with medications and not pace them. I'm not saying don't pace people. I'm saying that think about things you can do that are quicker and think about the patient overall. If you try to pace someone and it does not work, either it wasn't third-degree heart block or something's driving that. The heart's just so dead, it's not going to get better. And those folks usually go into cardiac arrest. You pick it up pretty quick. Or the other reason is the hyperkalemic, and the pacer doesn't work because they're hyperkalemic, right? Or they're so big, they're a true Alabamian, right, that the pacing pads don't work. But look at your doses for push dose epi. Make sure that you know how to give that and know what the appropriate dose is. We've already talked about dotism. We've talked about maintenance fluids for cardiac arrest. My advice is I'm not going to be doing lidocaine or amiodarone drips for people, and unless they're having runs of VTAC after cardiac arrest, after they've been shocked. A lot of times I'm thinking magnesium in these folks as well. It's a great dysrhythmic, especially if they have a long QT or torsades. I've already gave my spiel about dotism and the rest of that. All right, got voices in my head too. We've already talked about bradycardia, stable versus unstable.
Hey, Doc.
Yes, sir.
Since we're kind of at a little bit of a gap here.
Sorry.
So people
The gap.
are still asking epi questions. So one is please give your thoughts on when to give amio before epi.
Okay. Yeah. So if someone, again, remember the mainstay of cardiac arrest is the EMT care initially, right? Which is oxygenation, ventilation, early defibrillation, exposing the patient, getting that set up. As a medic, if you show up and the patient is in VTAC or VFib and you recognize that, and those other priorities are already done, and you have IV access, you can give amio for VTAC or VFib before you give your epi, if you wanted to. My thoughts are I'm going to give epi first, and then I'm probably going to give amio or lidocaine immediately thereafter and do a shock. Am I making sense to you? You're shaking your head.
It makes a lot of sense to me. I don't know why anybody would ever give amio first. So
yeah,
I mean, we've researched amio and shockable arrest, and we found that it had essentially the same efficacy as placebo.
Yeah.
So
the treatment for VTAC VFib is electricity and good BLS care, right? There's still a big push for amio and lidocaine. We still need to follow those guidelines. I think epi, first dose epi is great because it increases perfusion, increases heart rate. If they were in torsades and you give first dose epi, that also increases heart rate, which decreases the QT, makes things better. So don't get caught up in that. I would say it's the BLS care. Then once you recognize they're in shockable rhythm, you've done that shock, the next drugs you're going to be thinking about, all right, dysrhythmic and epi, or epi and then dysrhythmic, okay?
So we've also had the same version, different versions of really the same question.
All right.
Which is going back to this 3 milligram max dose for epi. So what if you get ROSC after 3 doses of epi? Then the patient goes back into cardiac arrest. Do we now start over with our epi?
So my advice on that was yes. You reset the clock.
I think so too.
You reset the clock.
I think when you have a major change like that in a cardiac arrest patient, you start over.
Right.
Just like if you got ROSC and the patient was in SVT, you would start the SVT algorithm.
Right. Yeah. You would not repeat that amio So you're going to max out your amio no matter what, and your lidocaine. So you're not going to start that over. But the epi you can start over because the half-life is so short. The reason I think the push for the decrease in epi is because when you start giving people a whole bunch of epi, you cause vasoconstriction and it kills the brain. So you may get the pulse back, but you're going to have anoxic brain injuries. But our job is to try to prevent those anoxic brain injuries, and we prevent it by doing great EMT care, early defibrillation, and that first dose of epi to try to get that shock to work, is my thoughts. And that's my Mountain Dew's kicked in, and now I'm getting confused, which is a great possibility. Remember, you got to understand the type of cardiac arrest you're treating. You got to know how to manage that patient. The protocol kind of backs that up. What is this? Nitro. I mentioned this because this can be used by the advanced or the paramedic. Sublingual. My advice on the blood pressure, I go a little bit higher than that. This is what this protocol state. I'm thinking 110, 120. It's all relative. The goal, though, is remember nitro can decrease blood pressure. Low blood pressure is bad. Bad for brains, bad for hearts. It can have bad outcomes. Also think about things that coexist, medications that can make nitro more efficient or drop your blood pressure, right? So certain medications that people take can mix with nitro and get really drastic decreases in blood pressure, such as Viagra, Cialis, those kind of medications. So medications, you can also give an ACS, heparin. Some areas in the state are doing heparin. Heparin's a great drug. It's kind of a blood thinner that is approved by your medical director. I think it's just critical care as well. Low pressure can be used in some events as well, but again, that's critical care. And remember, blood pressure management should be reserved for people, my opinion, after imaging to say they have a head bleed or ischemic injury causing their altered mental status. If it's cardiac stuff causing the blood pressure to be high, nitro is the drug of choice for that. If it's cocaine or meth or things making you hypertensive, benzos are the drug of choice, not these medications. Childbirth, we're going to cover this pretty hot and heavy in 2 weeks. I will remind you that Pitocin is a great drug to use for postpartum hemorrhage. If you don't carry it, it's cheap, it's easy, great resource for your community. The other good drug, postpartum hemorrhage, is TXA, which is IV push protocol now. We talked about CHF. Remember, with CHF, the main thing we're thinking about these folks, decreased cardiac output, right? So you don't want to slow the rate down as quick as you do other people's. And the other thing is pulmonary edema. We've already talked about our LMNOP. Won't talk about croup. Decompression sickness, don't see a lot of that. I know up in Coleman that the Smith Lake's pretty deep. We've seen some folks. If you need a dive chamber in Alabama, you're in a bad spot. You need to call a dive network. TCC can help with that. But there's really no good place to get someone that's on a ventilator to a chamber. I'm not going to talk about tasers or dialysis. I will argue, if you pick a patient up from a dialysis center or from home and they're on dialysis, and now they're altered, somnolent, heart rate is 30, what's the first thing you're going to do? First medication you're going to give them? Anybody care to take a guess? What do you think's going on? Dialysis patient, heart rate of 30. They have hyperkalemia, until proven otherwise, right? Kidney problems cause hyperkalemia. People who have a slow, wide QRS complex dysrhythmia, it's hyperkalemia to proven otherwise. So open the airway, somebody's getting an AccuCheck, nasal cannula, neb treatment on that patient because albuterol fixes hyperkalemia, right? All right, and then he gets IV access and calcium. We've already kind of talked about labetalol use, nicardipine. Places that I'm medical director for, we're not carrying labetalol. There's limited benefit for that in the field. In a facility, yes. Flight, yes. When you have access to patients that have been imaged, but otherwise, no. And then nicardipine and norepi, my suggestion is they be on a pump. Hypothermia, that doesn't happen often in Alabama. What is this one? Hypoglycemia. So State talks about they're going to review any use of an IO in hypoglycemia. That's fine. That's reasonable. Just make sure that you're doing this for the right patient. If the patient is altered, grumpy, glucose reads low, and you drill them because you've been to their house 4 times in the past month, that's wrong. That's an assault. You can't do that. Okay? You give them a bag of Skittles and a Mountain Dew. I got both if you need some, right? If they're altered and unresponsive and not talking to you, people die from hypoglycemia, and you can't get IV access. Their glucose reads low. They got some worse respirations, unresponsive. You've got to get glucose in people. People will die from hypoglycemia. Has anybody taken care of a patient that's a diabetic? Let me rephrase that. Who has not ever seen a diabetic in their life? Raise your hand. Very good. There are all kinds of medicines out there that lower your glucose now. There are people on Mounjaro. There are people on Ozempic. There are all these medications in addition to insulin and other medications. This is a common occurrence. If their glucose is low and they're obtunded, IV access and D50, D10, D25, whatever you have, because it's on back order a lot of times. If you can't get IV access and you don't have glucagon, you have to drill them to give them glucose. If you have glucagon and they're 6'2" and weigh 60 kilos, is that going to work? Probably not. They don't have any fat stores. They will get an IO. All right. So thiamine we've talked about. Don't use a lot of thiamine. If you want to carry it, great. If you don't, again, it's not as emergent as we once thought years ago.
Hey, Doc, back to the hypoglycemia.
Yes, sir.
Just want to make a point that the pediatric dosage from last protocol and this protocol is really janky. They're saying 4 milliliters per kilogram of body weight of the patient for D10, which by all national standards is an extreme underdose of dextrose.
Yeah.
For kids.
Yeah.
So
yes,
you may end up having to use more than that if you have an extremely hypoglycemic diabetic adolescent.
right.
That's my point.
Yeah. So again, I think what you need to do as an agency is you're going to have to look at the drug dosages of the protocol, make sure that you're comfortable with those, compare them to standards, talk to your medical director, and determine what you're going to do. All right. Hypothermia, what is that? Influenza. I think we're all about sick of viral illnesses. Benadryl can be used for antiemetics. It's an old school. Just remember, Benadryl will prolong the QT just like Zofran. Benadryl also zonks people. Benadryl is also a great drug of abuse. So you have a lot of folks that are using IV Benadryl to get high. So I don't use a lot of Benadryl for nausea unless I have to. You really technically, I guess you can't be allergic to Benadryl, but some people say they are. But just be advised that Benadryl will prolong the QT. It does cause pretty rapid somnolence, and people get a buzz off of it, okay? All these medicines here for nausea prolong the QT. And you've heard me talk about getting 12 leads on folks that are nauseous to look for that. Newborn care, we'll cover some in 2 weeks at Springville.
Hey, so Doc, on the prolonged QT issue to avoid Benadryl or Zofran for those patients.
Yep.
So how do we reconcile that with the advanced EMTs?
There's no way.
There's no way to reconcile it.
So what you're going to have to do then is go back to that history taking portion. What patients are at risk for having a long QT, right? So those patients are patients that are malnourished. Okay, those are patients that have underlying chronic diarrhea because you lose MAG stores. Those are patients on chronic psychiatric medications because that prolongs the QT, or those are patients on cardiac medications. So that's how you screen those folks out, right? Good question. Pain management, a lot of dosages here, choices, morphine, fentanyl. We've already talked about Toradol. Ketamine, my advice, if you're using IV ketamine, because that's all you got, talk to your medical director. Max dose IV is 25 milligrams. You can repeat it every 10 minutes. My advice, if you're giving someone more than 50 mgs of ketamine during the course of your transport of that patient, you need to think about doing something different or watching that airway. A lot of times this stuff gets cumulative. I can tell you cases where I've seen folks have got 25, didn't work, got 25, didn't work, so they gave them 100, didn't work, gave them another 100, and then guess what? You know what, right? Remember, 10 minutes is 10 minutes. 10 minutes isn't Well, it's been 2 minutes, but it feels like 10 minutes. This is cumulative. The other thing to think about when you're giving someone pain medications, think about the underlying issues with them. Are they post-cardiac arrest and hemodynamically challenged already? Is it a trauma patient with a femur fracture who may have a pelvic fracture, maybe having some blood loss or a head injury? The goal of pre-hospital pain control is to make it a little bit better, not take it all the way. Because sometimes if you take it all the way, you take it all the way by depressing the respiratory drive, and they can have a bad outcome or die. Okay? We're taking the edge off, right? We're like the first beer, not the sixth beer. Okay? Poisons. We talked about Narcan enough. I know time's running short. There are a lot of other ingestions, things that are out there. TCA is one that we talk about a lot in clinically in literature. In reality, you don't see a lot of those much anymore. TCAs used to be used for depression, and then in the 80s, 84, 85, SSRIs came out. You saw a decrease in that. You do see TCAs used in older people for chronic pain or depression. So maybe calcium channel blockers, probably more common. Those are folks on blood pressure medicines who have an acute kidney injury. Cyanide, I think, is the big saver here, the big win that we can catch, because it's pretty obvious. Oh, you were in a house fire and now you're altered unresponsive. Is CO inhalation injury or cyanide? For CO and inhalation injury, is advanced airway management, O2 you can give them. For cyanide, cyano kit, right? Benadryl, don't see a lot of that, but it's there as well. This is one I wanted to talk about for a few minutes and we may run out of time. So post-intubation sedation and CPR-induced consciousness. So we have some pretty good leeway to give medications to people that are intubated. But these are patients that are intubated, not patients that you're going to intubate. So you can't look at somebody and say, hey, this person has a GCS of 3, so they're unresponsive by AVPU. They're hypertensive, they're snoring respirations, they need an airway. So I'm going to give them, because I'm going to intubate them, I'm going to give them some ketamine and some fentanyl, and then intubate them. That's called drug-assisted intubation. You cannot do that as a paramedic. I would not do that as a physician. There are better ways to do that. That is critical care. There are ways we can do that and keep the patient from having issues and from killing the patient, to be honest with you. This is post-intubation. So that means this is the patient that you're going from hospital A to hospital B. They're intubated for their injuries or their illness. And en route to the hospital, they start bucking and fighting. You don't want to lose that tube. If they got a tube, pick what you want. Oh, this guy was a post-arrest and he got 14 milligrams of Narcan by fire. Now I'm going from hospital A to hospital B. I probably won't give him any fentanyl because he's got Narcan. It won't work. So I'm going to go down and say, oh, I'll give him some Versed or maybe some ketamine. Super reasonable. If he was hypotensive, I want to give him Versed. Versed drops your blood pressure. I would go to ketamine instead. Does that make sense? If it's a trauma patient that has active extrahepatic, they have a pelvic fracture, you're going from hospital A to hospital B, they're intubated, their blood pressure is 80, they're on the ventilator, and now they're bucking and fighting you, I'm probably going to give them fentanyl. It doesn't affect the blood pressure. It might affect their pain control, so we don't lose that tube en route. That is my interpretation of the way this should be run. But I can tell you, this is not to give somebody these medications and then take an airway. This is not drug-assisted intubation, okay? If it's post-cardiac arrest and the patient is hypotensive and they start chewing on the tube, don't slam them with Versed or fentanyl, things of that nature. Give them a little bit. You want to keep their blood pressure up so you perfuse the brain, all right? And this is also for post-intubation, which is an ET tube, paramedic or above. This is not post-iGel. This is not post-King Airway. This is not post-nasal trumpet and passive O2. It's post-intubation. This will bite you. There are a lot of medications for critical flight guys. You can use VEC, you can use Zimuron, you can use Pavulon, whatever you got. Sometimes you got to paralyze these folks to make it safe in the aircraft, or you got to paralyze them to control their ventilations and oxygenation on the ventilator. That's reasonable. If you paralyze somebody, they need sedation, but pick the right one, all right? Hypotension does not get Versed. Maybe they get Ativan, maybe they get fentanyl, maybe use the ketamine. If the patient is an asthmatic or COPD or has some kind of interstitial lung disease, ketamine is a great drug for that patient, okay, after they're intubated. Do not give these drugs in anticipation of them being intubated. That's not how it works. Eclampsia we talked about, Magnesium's the drug of choice. You can only give it if you got it.
Hey, Doc, that last protocol also talks about people having periods of lucidity on the Lucas device, essentially.
Yeah.
What we see rarely.
Yep.
Personally, I don't think I would ever sedate anybody.
Yeah. So I'm not gonna. So my practice, I'm not gonna throw something in the mix either. So if I got somebody on the Lucas, and the Lucas is chewing, and they look at me and reach up and flip me off, and I say, "Great, they're alive." I turn the Lucas off, and they die again. Okay. I turn the Lucas on, they start going again. I'm probably not going to sedate them because I'm throwing things into the mix that can mess up my assessment of what's going on. Yes, would it suck to have that happen to you? Probably so, but I think it's more of a rarity, and it's not that common. State says you can do it. I'm not going to be pushing Versed or fentanyl, Ativan, or ketamine in a cardiac arrest. And unless I think those medications are clinically indicated for that cardiac arrest. If I have an asthmatic who's gone into cardiac arrest, they're hard to ventilate, yeah, I may give them some ketamine because ketamine is a great bronchial dilator. All right. So my salvage drug, my go-to drug in asthmatics, I got to put on the ventilator. All right. Does that make sense? So, thank you, sir. Again, a lot of information on these protocols. I think I have a few minutes. Let me see what else. Seizure dosages. Just review the dosages for Versed. There's some different dosages throughout the protocols. Just look at those, be medical director, determine what you think needs to be done based upon that. Keppra, I want to mention. So I'm not familiar with this is a pretty large dose of Keppra. This is critical care. Keppra is an anti-seizure medicine. I base it based upon what's going on with the patient. Are they in status epilepticus? Or am I giving Keppra because they did seize and I think they may seize later? Or am I giving Keppra because they have a head injury and some blood in the brain and I don't want them to seize? And it's weight-based based upon what's going on with them. I don't do 6 grams on anybody. I'm maxing out at 4.5. Dr. Power, are y'all seeing more on that in the trauma bay, or are y'all going to these higher doses? Yeah, yeah. So status maybe, if you look at the literature and talk to the ER pharmacologist, they're saying 4.5 grams is max dose. So talk to your medical director. If you're an agency doing critical care that I'm over, we're going to do weight-based with a max dose of 6 grams because that's a big dose for some people. And again, it depends. Status, yeah, makes sense. Maybe going a little bit higher. If this is prophylaxis for head injuries, I'm probably not giving 6 grams. So again, talk this over with your offline medical director and determine what you're going to do. But I'm going to use that as a max dose for me. And in reality, until I see something different, I'm probably not going to go over 4.5 grams. Sepsis we've talked about. I know a lot of folks are carrying, and I want to carry antibiotics. That's very reasonable. I think the more important thing than the antibiotics for the pre-hospital care, and unless you have long transport times, is recognizing sepsis, initiating things to correct oxygenation, ventilation, initiating good blood pressure management with IV fluid volume resuscitation, and either push dose epi or your norepi on a pump, and then making the hospital aware, hey, Mrs. Smith in the nursing home got a blood pressure of 80 when we got there. She got 2 doses of epi and she's on norepi now with the blood pressure of 100 and still tachycardic. I think she's septic. Use those key phrases so that mobilizes that ER staff to get the appropriate antibiotics. Rocephin's a great drug if you got a UTI, if you got some pulmonary things, or you got meningitis. It's not a great drug for everything. Ancef is a great drug, in my opinion, for skin wounds, open fractures, some cellulitis. But if I have somebody that's truly septic and septic shock, I'm picking stronger antibiotics than this because I don't want them to die. What is that? We talked about Levofed and pumps. My thoughts on that.
So, hey, Doc, on the antibiotics, is
Yep.
there anything if they're in septic shock or they're septic and we give one of those 2 antibiotics pre-hospital, does that interfere with you giving different antibiotics clinically?
Not really. Not really.
I know it interferes with the culture to some degree.
Yeah, it does. It does. From an ER perspective, I care deeply about obtaining blood culture, meeting metrics, but patient care comes first. If that patient's in front of me in the ER and they're like hypotensive, tachycardic, altered, and I have to stick them twice to get blood cultures, I'm not doing that second stick. I'm giving the antibiotics because treatment trumps diagnostics. So not really. I think that the sepsis is such a broad term, and based upon what infection that patient has, what part of the body it's at, and based upon where you are determines what antibiotics. Every hospital does a antibiotic gram. Am I saying that right? Antibiotic gram, maybe? I don't know. It's a chart that shows you which drugs are more common, more prevalent in that community, and which antibiotics work best against it. So you're better off giving the first antibiotic being the right one than mixing it up by doing others. Is there a big risk? Probably not. The risk is in delaying care, in my opinion. So if you're going to use antibiotics, talk to your offline medical director, talk to the hospital or hospitals you transport to, so everybody's on the same page and they understand what you're doing and why you're doing it. And I get it. Timing antibiotics, super important to keep people alive from sepsis, but appropriate antibiotic is also important. Let's see, what is that? Push dose epi, again, double check your dose. I think that dose is incorrect. Stroke, we've already talked a little bit about, won't go into details. And what is this? Oh, this is also, if you look, the EMT can run 12 leads. You can't interpret them, but you can have an EMT on scene with a monitor that does AED in 12 leads. They can take this patient that's 40 and sweaty and diabetic and say, oh, that makes me think ACS, acute coronary syndrome. Let's get a 12 lead. Oh, that 12 lead reads out acute MI suspected. They can send that to TCC, put them in the STEMI system, and either get ALS transport, or if it's a BLS transport agency, pick them up and move to the hospital that way. All right. So if you're doing BLS transports, you should have the ability for your EMT to do 12 leads and have an AED. And I would also say capnography too, because that's in the state scope of practice. Vaginal bleeding, we'll cover that next time. We've talked about trauma. We talked about passive O2, blood products, TXA. What is that? Hyperventilation. We always talk, historically we talked about you hyperventilate people that you think are herniating in front of you because you blow off CO2, vasoconstriction decreases brain swelling. And my argument is if they're herniating in front of you, they're probably going to die. If they're herniating in the trauma bay and neurosurgery is not taking their skull off, it's probably too late for them. So there's no reason, my thoughts, to hyperventilate anybody in the pre-hospital world. Yes, recognize what you think is going on. Yes, manage oxygenation, ventilation, making sure they're not hypoxic, keep their blood pressure up to perfuse the brain. As an advanced MT or medic, again, TXA, so if there's blood in there, they don't bleed anymore. If you want to do some 3% saline, great. If you're critical care and want to give mannitol, great. I'm not a big fan of that either. And if you decide to hyperventilate, which I don't recommend, the goal is end-tidal CO2 never gets less than 30. Less than 30, we know people die from that. Okay? If you're a flight crew and you got a guy with a head injury, and on the ventilator, you set your vent settings perfectly, and the patient is breathing 30 times a minute over that ventilator, and your waveform capnography is going at 30 times a minute, and end-tidal CO2 is 22, what can you do to fix that? A little bit of post-intubation sedation, fentanyl, some Versed, some ketamine. That doesn't fix it. You give them ROC or VEC, and you take over their airway. Now their end-tidal goes back to 36 to 40, and you prevent that cerebral vasoconstriction, and you perfuse the part of the brain that's still alive. So you can get really deep. I won't say in the weeds because it's important stuff when you start talking about some of these processes, okay? So you cannot use the protocols as your only your only guidebook, your only source of from the kind of patient you take care of. You got to know what you're doing. You got to have a relationship with your medical director so y'all can talk about these things. You got to have a way to have a QI process so you know when you do a good job or a bad job, and you got to get follow-up. If you don't have that, you're missing out. Reach out to me or somebody. We got to make it better. What we got here? All right. 4 minutes over, and that's everything but the medicines. Again, this is not all inclusive. Please, as an EMS agency, the EMS officer at your agency, is the administrative leader, is the medical director. Look over these protocols. If you have questions that I can help with, reach out to me by email or text. If you have questions that the state needs to respond to, reach out to them. The goal of this is to provide the best care we can for our patients, right? Cool. Questions, comments, statements within reason. I feel very uncomfortable with the crowd in the back. They all have a stern look in the face.
Well, I got a bunch of questions about antibiotics, so I may have opened up Pandora's.
Pandora's box, yeah.
So
it's in Vegas, isn't it?
One of them
That's
kind of encapsulates a group of communication. Your belief in antibiotics for trauma is the way one person phrased it. Another one was all multi-system trauma, antibiotics, question mark. So any thoughts on that?
Open fractures, ANSEF is reasonable. It should not take away from the priorities of care, which is oxygenation, ventilation, control hemorrhage, TXA blood products, and rapid transport to definitive care. But if you're buying time and transport, you got extra hands, and they got an open fracture, and you want to give the 2 grams of ANSEF, that is very reasonable. Yes.
All right, and actually, a handful of people have asked IV or IM on antibiotics.
I would do IV. I would not do IM. If you have someone that you're giving IM antibiotics to, in my mind, that makes me think, oh, they're doing great. They got good perfusion to the muscles, so it's going to work. If they got good perfusion to the muscles, EMS should not be giving them antibiotics. We're giving antibiotics to people that we think are going to die because they're septic or have an open fracture.
Yeah, I would agree with that as well. All right, any questions from anybody here in person and YouTube? All right, so you covered a whole lot. We appreciate you, Dr. Ferguson. There's a lot of sentiment that's been coming in about how much this was needed, and thank you for doing this.
Sure.
I know that you can't cover everything in the Alabama treatment protocols in 2 hours.
No way. But EMS Challenge, my goal, I meet with the resident class in 2 Thursdays from now. I got 13 new residents that are second years. They'll be divvying up topics for the course of the year. We've got our most of the agenda through December where we're going to be posted already, and we'll have those topics posted by August. So we're going to cover important things so that you can use that information we give you, look at the protocols, look at the other data, and then make a reasonable decision on how you're going to manage these patients at that point. So 2 fellows, 13 residents, we should have a good year.
Yeah, I think so. So just a reminder, if you haven't already done so, please fill out an attendance form for today's class. I'll put the QR code up on the Teams meeting here in a minute. It's also in the Q&A section. If you're watching online, in person, we've got some flyers that we passed around. You can scan the QR code. The password for the attendance form today is the word protocol, all lowercase. And if none of those mechanisms work for you, you can send an email to alabamaemschallenge@gmail.com. You'll get an automated response with a link to the attendance form.
Yep.
So we had great attendance online today. Thank you, everybody, for participating. And we'll see you in Springville, Alabama.
Springville in 2 weeks. We're going to do OB emergencies with Dr. Power. And then one of the fellows will do a critical care pharmacology class. Cadaver lab, September the 12th. And then that weekend, and then I had one more thought, and I just lost it. So I guess that's it.
That's it. Thanks, everybody. See you next time.